I'm glad that with the help of our Ajay Kumar from the HCG group, he has helped us achieve what we wanted to do, and finally we have now come up with the latest and the top level PET scan in the country. And thank you very much once again, Dr. Ajay Kumar, for helping us, because this this uh, this cancer center was set up 14 years ago by a group of doctors here in Kenya, with the help of the owner of the Sarit Center, Bachubai Shah. He was encouraging, he gave us all the resources in putting it up. But we were a group of radiologists and other doctors, and not that very knowledgeable about cancer, and it was a big struggle for us to run the cancer center that we set up 14 years ago, and we were running in big trouble. And then I was introduced to Dr. Ajay Kumar, and I went and visited him in about 8 or 9 years ago. I traveled to Bangalore and met him. In 10 minutes meeting with each other, we were holding hands, and we had become big friends, and he said, I'll come and help you. And I'm so glad that you came to us and helped us, because otherwise we would have collapsed. We would not have got back to where we are now. And I think now, in the last particularly 3 years, I think within this East and Central Africa, we have become a leading cancer treatment center, and we are looking forward to growing with you in the years ahead.
The chief guest, Dr. J. Kumar, the chairman, HCG, distinguished colleagues, ladies and gentlemen. On behalf of GE Healthcare, it is a great honor to be here today at the opening of this groundbreaking healthcare facility with a top priority PET CT from GE Healthcare. We are honored and committed to our partnership with HCG CCK. This partnership underscores an unwavering commitment to the private sector healthcare in the remarkable country of Kenya. Today, we celebrate a significant milestone: the introduction of the first Oncology PET CT and IMRT Center here in Nairobi. This state-of-the-art facility represents a leap forward in precision diagnosis, quantitative analysis, and optimized care continuum in oncology. With accurate diagnosis and monitoring of treatment response, we are paving the way for better patient outcomes and a brighter future for healthcare in Kenya. Our collaboration with HCG is a testament to our shared vision of providing the best healthcare solution. Together, we are not just investing in technology, we are investing in healthcare and well-being of the people of Kenya. This center will empower healthcare professionals with tools they need to deliver exceptional care, and it will offer patient access to cutting-edge treatment that was previously out of reach. Lastly, as we look ahead, we remain dedicated to Kenya's healthcare journey. We believe that through innovation, collaboration, and steadfast commitment to excellence, we can make a profound impact on the lives of countless individuals. Thank you for being part of this momentous occasion. Together, we are transforming healthcare and building a healthier future for Kenya. And once again, congratulations to HCG for this great milestone. I thank you.
We had planned this PET CT for here about 10 years ago, but for various reasons it was not happening. Finally, for the last 2 years, we started doing it. We wanted to invest in cyclotron also. but something that's changed rapidly. And today you don't need a cyclotron to do at least 90% of the work. We do around 14 different types of PET scans in Kenya or elsewhere, anywhere in the world. PET scan means FDG, the first one. Okay. We don't do FDG in our center. We do it very less number of patients only. Why we are bringing so many molecules? Because all cancers do not take up FDG, and all cancers behave differently. So we have developed a lot of new tracers meant for specific cancer. So if this is a cancer, we are going to use that molecule only. What has happened? This will make your diagnosis most accurate, easier accessibility, because these molecules are not available, and I can proudly say that not many centers in the world today do this many PET scans. At present I have enumerated only 4. We have just started. We will definitely add another 6, at least 10 different types of PET scans. So you will be on par, even better than European counterparts or in USA. So we are bringing the cutting edge technology for betterment of your patients, better diagnosis, and I am very happy that we have set up and we are getting a good feedback already. We have started doing about a month back. We are doing quite good number of patients, and with this particular different types of PET scans, it will definitely help to diagnose your patients better and treat the patients also better. And we are moving towards what is called as precision oncology. To be very precise, you need a precise diagnosis also. So I can proudly say that Kenya has got now one of the best centers for the PET CT, and your patients ultimately will get a better treatment.
It's a new leap into the future for the Kenyan patients. I keep coming here every month from India, seeing different kinds of patients. I think most of them travel to India for a good quality PET CT scan. But now we have here where you can get top quality PET CT scans, which helps our doctors to decide on the appropriate treatment and make impact in this geographical domain. I think you can see the number of patients which have already undergone the PET CT scans and the impact it is created, and hopefully by adding more amount of molecules and creating much impact, and this is also going to help the doctors in precision oncology. With this, thanks and best wishes for the team as well.
Thank you for that warm welcome, and all the distinguished guests and my friends. It's indeed an honor to be here, mainly because, as you know, the history of this cancer center belongs to really Dr. Adam for what he has done, and without his vision, he's a visionary. How we started the Oncology Center, how partnered with Mr. Hcg Patel and his family. Wonderful vision. The base was set. But as Dr. Adam Ali said, challenges were faced. And what we in HCG specialize is in challenges. We love challenges. So when there was a challenge, it was easy for us to say, as we know most of the hospitals which come from India, without naming anyone, are there to lure patients to come to India. It is financial, they use touts, intermediaries, everything. And the main thing is, if we think the patients are beneficiary, yes, but they also go through a lot of turmoil, getting a visa, coming to India, unknown place, staying, and a lot of them come with advanced diseases. This is when I went against the grain. And when Dr. Adam Ali came, I said, this is what we have to do. For me, I consider myself honestly a global citizen. I was in US for 25 years, came to India to make a difference. Similarly, I said, I may be Indian, but I'm global. And definitely East Africa needed an advanced cancer center. And we were very fortunate also to work with MP Shah Hospital. Dr. Tassim Din is here. Thank you for coming to see him. And we really want to work as a collaborators. And they have, MP Shah also has a vision to bring highest possible care for this part of the world. And in oncology, which is so specialized, I know today evening we are having a long discussion, but I just want to say every 3 months oncology care is changing. Every 3 months. Precision oncology. It is very difficult for patient to do online or patient to go to India for a short time, spend enormous amount of money and away from family and to get treatment, and we don't even know what will be the outcome because of the magnitude of the issues. So what is the best thing to do? Bring the center of excellence here. And that is what we have done, and that is what we want to do. With your cooperation, we can do it. I think we should take pride in it. Not sell the patients, come to India. Yes, there may be a reason. There may be times for certain things. But majority of the people should be treated here. That is where they can get the best of care, provided we have the center of excellence. Long time ago, just to give you a parallel, when I was in US and trained at MD Anderson, center of excellence was US. But in the short period of 10-15 years, we have brought the Indian platform. HCG has been a trendsetter, and we are a Harvard case study 5 years in a row because our quality of care is unmatched and equal to best of centers in the world. We have achieved it from nowhere to that. And let me promise you, my dear friends, we can achieve the same thing here. And for me, we love Kenya. We think people are wonderful, people are so good, and the weather is great also. Okay, so we can. And only thing is we have to come together, not have doubts, issues. Trust is an important thing. If we trust each other, I would promise you one thing, and for my whole team, Bhupendra and the whole team, money comes and goes, but we want to do right thing for the patients. And that HCG promises to. And what I want to say, we have stalwarts like Mr. Bichu Patel, Adam Ali, and their families. It's everyone who are dedicated to this, to bring that quality of care and excellence here. This is only the PET scan launching. We did the LINAC launching few years ago. We brought the highest possible linear accelerator in the world. Dr. Adarsh is here, who superheads it. We brought it, and we will continue to do that. We do SRS, SRT. We do highest possible care here. And we want to continue that, and PET scan is a great addition. I always felt, I remember the days when the first PET scan came to US. First PET scan to US. Mesmerizing, molecular. I can actually detect a single cancer cell, where it is. It's amazing. It was as big as a big football field, cyclotron. Not big. Now we have brought it smaller. As you can see, cyclotron is not there. We don't even need, as Dr. Kallu said. So with this advanced technology, I join you all in saying we are proud we are able to deliver this with lot of hardship. Yes, hardship is always good. Hardship teaches us lesson. So with this, we have achieved this, and going forward, I like to promise one thing, that we will be sincere. We work closely with our colleagues, closely with MP Shah Hospital, which has been very cooperative, closely with all our doctors, colleagues in this part of Africa. And I want to work hard, whether I succeed or fail, I am not sure. Work hard to make this center a center of excellence, a comprehensive cancer center which provides equal outcome as best of centers in the world, or even maybe better. With this promise, I like to conclude, and thank you very much for coming here. Thanks a lot. Thank you.
sheds many tears while we all sup sorrow with the poor. There's a voice that will linger forever in our ears. Oh, hard times come again no more. 'Tis the song, the sigh of the weary. Hard times come again no more. Many days you have lingered forever in our ears. Oh, hard times come again no more. Will we see not the beauty and music, light and gay, their
Ladies and gentlemen, please put your hands together for her. Thank you very much, Serafin. Thank you. Please, one more time, ladies and gentlemen, put your hands together for Serafin Moipe. Thank you very much. Phenomenal. Thank you. Story of hope. Indeed. Thank you, please. One more time, ladies and gentlemen. Thank you very much. Beautiful. Ladies and gentlemen, at this particular juncture, I'd like us to kindly be up on our feet as we welcome the Executive Chairman, HCG Enterprises. Please, I'd like us to stand up tafadhali for this one as we put our hands together and celebrate and welcome Dr. Ajay Kumar to come and give his address this amazing evening. Please, a round of applause for him as he comes on up. Please, makofi kwake tafadhali, ladies and gentlemen, as he comes on up.
Good evening, everyone. To begin with, you heard the music of Serafin, you know how we can really win the war on cancer. It's an outstanding example. That is what precision medicine is. And today, while we go through more details about molecular imaging, I would like to set the stage for what true oncology care is, so we can better understand the importance of molecular imaging and all other forms of precision diagnosis. One thing I would like to say, in 50 years of oncology I've been practicing, started in 1975, trained in one of the biggest institutions in the world, MD Anderson. Even after 50 years, oncology is so dynamic, so ever-changing. I will say unashamedly that I am not an expert in oncology. Because no one can be an expert in oncology, the way things are changing. Understanding the disease is itself an enigma. Cancer is an enigma. And if somebody says I'm an expert, I don't think we can believe it. It is such magnitude, we have to go into the depth. Why two people who are treated the same way, same disease, why one responds and the other doesn't respond? What is the meaning of staging? Is there anything like staging really? What do you mean by saying somebody is stage 4? When somebody with stage 4 can live with lung cancer for 6, 8, 10 years or breast cancer? Do we need to use the terminologies like palliative care, terminal care? Do we really need programs like hospice care and all? That is why HCG today have hospice care. Because even in advanced cases, if you treat the patient properly, identifying where the pain can be coming, they can lead a normal life. We can have patients with extensive disease in the lung or bone, but walking like normal individuals. So it is the way we manage cancer. And the enigma of cancer is understanding. For example, when you look at, I'll give one example, prostate cancer, which is fairly common here, and we don't know why. We need to start collecting data, which I'm determined to do. Why is it so common in this part of the world? It almost always goes to bone or regional lymph nodes, but very rarely goes to brain or lungs or liver. What is the genesis of this? What are the gatekeeper mechanism? What is the immunity? Where are the T cells? What are the protective mechanism? Why is it when they enter the bone, it opens the gates as though they are friends? Why is it when it tries to enter liver, it blocks off? Similarly, cervix in women, which is anatomically close to prostate in men, almost never goes to bone. Very rare. What is the reason? When we don't know these reasons, can we be experts? Definitely not. So what I would like to share with you today is how do we unravel this mystery of cancer? How do we try to win the war on cancer? Today cancer is very common. We know in Western world document 1 in 7, 1 in 9. Breast cancer itself is extremely common. And in countries like India, head and neck cancer is extremely common, 38%. Here in this part of the world, prostate, cervix cancer are very common, esophageal cancer. And what is the genomics of the individuals? A Caucasian genomics, is it applicable to the Asian or African genomics? Certainly not. In our own study of 2,000 patients, we have shown 38% of the time in Indian population there is a variation in the genomics. But we treat them the same way. We use the same protocols. Is it not time we analyze patients in different sections, parts of the world, and understand their genomics to come up with the right treatment the first time? So the whole idea is, how do we treat these patients the first time right way, so the recurrence rate comes down. In our center, we audit across HCG. We see 120,000 new patients, 26 centers. Audit. My job is to audit mortality, recurrences. Why do recurrences happen? And why do we treat patients? Suppose we say there is a protocol to treat tongue cancer or even prostate cancer. Where a patient asks, what is my chance of recurrence? Based on the studies and all, 50, let's say for the sake of this, 50% chance of recurrence. Why are we giving the same protocol knowing 50% are getting unnecessary treatment? Because that is what the protocol calls for. And then we use the common terminology, community practice, academic practice, research. My friends, I can say one thing. All of them are blended into one in today's oncology management. Nobody can say, I'm a community practitioner, I'm a researcher, all of them has to be done. And that is what HCG has shown. With innumerable papers, high-end genomic work, and monitoring the recurrences, bucketing them, and understanding why recurrence happens and how do I treat the next patient. Each patient is valuable for us. It is the way we go into the depth of each patient what gives us an answer. Superficial treatment will never give. I find our oncologists most of the time, majority of the time in the tumor boards, when we present case of a recurrence, the second line of treatment, combination of gemcitabine, combination of taxane. Man, why did the recurrence happen? Are we understanding? Is it biology of the tumor? Is it a technological gap? Or is it something else? What is it? Only understanding that we can treat the patient properly. Even the first time when we see a patient, we should understand why the disease has come. When a 27-year-old presents with breast cancer, recently I had a 17-year-old girl presenting with liver cancer. Why should it come in them? What is the genotypes? What is the mutation? Is there any indication so we can treat this patient right way the first time instead of just going with the protocols knowing there is a high chance of recurrence? Of course, there are protocols which give you 80-90% disease-free interval, early stage breast cancer, depending on what the markers are. Even there are various triple-negative breast cancer, as we know, totally different from others. And how do we analyze? So I will take you to next few minutes, a small journey, and present some cases to show, primarily this is to show that it is a vast subject, it is a complicated subject, it requires a team effort, and no individual anymore should be. It requires radiologists, molecular diagnostics, pathologists, and genetics, molecular diagnostic people, medical oncologists, surgical, radiation, and clinical pathologists, all of this, psycho-oncologists, to really come to a decision. It's to the patient, what is the right treatment. And the patient and family are an integral part of this decision making, to explain to them why we are doing what. And this is how oncology is practiced. I call it the art of managing cancer. It's an art, like an artist doing a painting, it is an art. It cannot be anything except an art. Only then you have a chance of succeeding in proper management of these cancers and not using the terminologies. So this is the journey. I'll just won't make my, just to show how cancer can be treated first time the right way. And accessibility, affordability, and of course, quality of treatment, all of them matter. And how do you create hub and spoke model so people don't have to travel long distances? This is to show how cancer incidence increasing. As you can see, even in Africa, cancer is going to increase dramatically. It is increasing, and as aging process, as environmental factors hit in, dramatic increase. And my interest primarily here would be to understand why there are certain diseases rapidly showing up in this part of the world, particularly prostate cancer in men. And this is again showing the same thing. Now this is the, how things have evolved. When we first moved back to India, we were like cobalt therapy. How are we managing? The world had given up cobalt, but we were still doing. The common answer was, we can't afford. I said, cancer doesn't know rich from poor. Cancer doesn't know he's a poor guy, let me be soft on this person. It doesn't work like that. It's the right way. By using treatments like cobalt, we were actually causing more harm than the actual treatment because we were treating normal tissues. So at one time, the public opinion was treatment is worse than the disease. Why should they undergo? Why should I undergo treatment? These were all the myths of cancer, and we have to demystify that. And technological evaluation. How do we bring about all this? And in this technological advances, one of the premier thing I noticed, even when I was in US, when the PET scan came was, wow, what a way of making diagnosis. What a way we can actually tell where is a single cell, somewhere it has spread. So accurate staging, and you will hear more about this in the next few minutes. But what I want to say is, that is one part of it. Genomics, personalized medicine is the second part, targeted therapy. And why even in genomics, why certain things work, do not work, what is the role of proteomics? For example, thank you. For example, there is DNA. So then there is RNA, where the mutations are. Then is proteomics, protein. So there may be a mutation. We may say this is ALK mutation in lung cancer. Then suddenly the treatment will not work. Herceptin for breast cancer may not work. Is it related to the protein content? So is it because of that the treatment is not working even though it's supposed to? So with proteomics, we can actually measure the length of the protein and actually come up and say, for this patient it's not going to work. And I'm very happy to say, we are just now in the process of installing the world's most advanced proteogenomic equipment. First time around, actually coming around with Thermo Fisher, which will give us this answer and complete the loop of this kind of precision management. And as we all know, cancer care is an evolution, past, present learning, future progression. We always talked about, bedside to bench. What do we learn? We take it to the bench. But how do we bring from bench to bedside? People used to wait for years. It is in the research process. But one thing I want to say is that is today itself. What we do in research can be applicable to the patient right away for that particular patient. And that is how things have advanced in precision medicine to be able to bucket it and find what is the right treatment for that patient. And that is why my clinic is an advanced and recurrent tumor, where when everybody says cannot be done, how it can do, what is the role of hot tumor, cold tumor, where does immunotherapy work, where does it not work. So when you go into the depth and repurpose medicines, old medicine in a new bottle, antibody drug conjugates, all of this will make a huge, can we use an old drug, can make a huge drug in how we treat. So this is again an Indian study where they show that significant number of patients that we are not treating them the right way the first time itself. So that is where we have to go. This is how the technology has made a huge difference. As we know, we have various forms. We talked about IMRT, IGRT, precision medicine, proton therapy. All of this have come of age, and we talk about NovaSeq, which is the genomics. What we are getting is the astral mass spectroscopy, molecular genetics, and spatial genomics. In spatial genomics is where we identify heterogeneity of the tumor. And with digital pathology, we are doing it today, where we can overlap the genomics on the digital pathology to say where are the genomic mutations, where the normal cells are, and how this treatment will work. Why is it this treatment may not work in all patients? So this is how we come to some of the answers. This is how HCG journey is. I'm very happy to say that we came into CCK here in 2017, and it has been a great journey for us, making this, working towards making it a center of excellence in Nairobi today. So it is the number of centers what we have, oncology chain. With this, we are collecting, after the platform is set, huge data. We have become a data machine. We work with AI, artificial intelligence, computational work. Accenture is the partner to collect immense data for these patients, to understand the disease better. And with this, how we can actually deliver the right treatment the first time, as I said. In Kenya journey, as I said, how we came, and I want to hear truly recognize Dr. Adam Ali, who is the first radiologist who actually started the center, and we were glad to be partners with him. Thank you, Dr. Adam Ali, for this, and I really hope together we can create a journey along with Dr. Biju Patel, and it's a great journey for us. Thank you. And again, in Kenya, we know the population is 58, and total number of new cancer patients diagnosed, you see it here. Cancer deaths are so much, and leading causes of death are breast, cervix, prostate, esophagus. And this is again showing destination. How do we become destination? When people recur, patients recur, they have to come to the destination center. And the idea is to make this a destination center where people can get complete treatment in terms of not only diagnosis but therapy and do the follow-up data for the patient, and publications, research can happen simultaneously. And this is the show how we are established an institution research committee, and we want to make Nairobi also as partners with us in this IRC. And this is where members have come up with ideas, what kind of protocols they want, and based on that, they do a trial which will be funded by us. We have significant funding for that, so that our own institution, not funding to some other agency. And with this, we are able to do nearly 61 trials we are doing now. One of the important points I want to make here, for example, immunotherapy. We know immunotherapy is quite expensive. It is patented. But biologically, we believe lower dose of immunotherapy is as good as higher dose, maybe 25% of the dose. And biologists have made some of the publications saying that impact of immunotherapy is not dose dependent. So we have done a trial for buccal mucosa where we have shown low dose itself, only immunotherapy itself producing complete CR. We have collected now about 18 cases. We are in the process of collecting up to 50 cases so that we can do a publication on that. Of course, pharma companies may not like it, but that is not our problem. But it is really, truly path-breaking if we succeed in showing low dose is as good as the high dose. So this is the Harvard publication showing that value-based medicine, cost versus outcome. Even though the cost is much less, our outcome is the same. That is what value-based. This is a 5-year they did a study on us and published 5 years in a row, Harvard Business School. This is the tumor microenvironment. I'll just kind of go through that in few minutes because I don't want to take too much time on this part, just to show you how complex it is. It is not only the cancer, it is the tumor microenvironment. TILs, hot, cold tumor, PD-L1, VEGF, all of this, FOXP3, all of this makes a difference in how we treat this patient. Some of the markers there. So we do complete 500 gene sequencing, not limited, because we need to get as much of information as possible. And we have been able to bring down the cost significantly because of the volume. When it started, it was costing in terms of dollars nearly $2,000 to $3,000. Today, we are able to do less than about $600. And we believe we can bring it down to $100 at some point based on the volume, and it can become applicable to everyone as we move forward. As we know, cancer increasing, complexity cases, evidence-based diagnosis, all of this biomarker research, genomic data, all of this have become integral part of how we manage. This is how the reports are put out in our centers across to detailing what are the pathology, what is the hot tumor, cold tumor, what is the stroma, what is the microenvironment. So this gives a good view to the doctor to working with the clinical pathologist to see what should be the right treatment. And this is how the digitization takes place. We are hoping we'll also put the digital here in Nairobi very soon, so we can sit in India together with the pathologist here, we can work out. Diagnosis, prediction, research, drug discovery. We want to go into drug discovery based on this. As I said, Indian genomics may be different. How do we do that is the question where we are moving. In HCG, we are establishing a separate company as part of HCG, which will have artificial intelligence, data scientists. We already have, And interpretation of these things together as a 24/7 work for us to come up with answers to these enigmas of cancer. And this is to show here how in HCG data, global data, HCG, hot tumor 61%, PD-L1 78, pretty much close to what global data, but maybe more immunogenic tumors compared to global. And TILs in head and neck cancer site-wise, as you can see again here, there is differences in the site, and it looks as though, GBS, nasopharynx are very high in PDL, immunogenic, potentially highly curable when they are immunogenic. Maybe the role of surgery will become. So all of this shows how, when properly managed, we can get, this is showing in our own HCG. One of the things I want to say here is, we want to do the same thing here in Nairobi. When we talk about data, it's very easy for me to pull out data from global studies. For I can say, MD Anderson this study, Sloan Kettering this study. We should not be followers. We should take pride in doing ourselves. Collect our own data, understand our own people, understand our own disease. Not be followers, but be leaders. As long as we are followers, we will never really succeed in our goal to win the war on cancer. Let somebody else do the publications. I will see the protocol and do it. It's an easy way out, but that is not the right way. That is why in HCG, we never look at global data unless for comparison. We see what is the HCG data, what is the global data. Outcome of disease, breast cancer, what is HCG outcome, what is global. And can we better? I can tell you one thing, the type of doctors we have in Africa, in India, China, brilliant. We are very capable. We are capable of research. Why do same doctors go abroad and get a great name? Because they are very good. It's just opportunities, and taking pride will make a huge difference. So that is what we are trying to do, to say why not our own. Sometimes I tell our doctors, don't even know what is other world is doing. Put your head and study what you are capable. Let us see what is our data. Then we'll compare it. Why should we really know what others are doing until we ourselves go through? Let it be a long process. Let it be a difficult process. When you go through difficult process, the rewards are more compared to easy process. So we have to take the difficult path in a disease like cancer. So this is again showing different tumors, HCG data, Indian data, and global data. How do we compare? How do we look at outcome? Becomes very important. And PD-L1 again, the immunology. So I will not spend much time just to show it's a complex system. That is enough to show how various factors are involved at the microenvironment, at the cancer level, to see what is the role of T cells, what is the role of NK cells, and what is the role of body, as I mentioned, where does it go, why for example, brain tumor, astrocytoma, why does it go outside the brain? But from outside body, it goes to the brain. Why not reverse? Astrocytoma rarely spreads. So this is the enigma of cancer we have to unravel. So in spatial omics I told you about, this is how we monitor recurrent cases. What are the recurrences? And we also go after the doctors. Doctor, you treated this patient, please explain why the recurrence happened. So doctors should be explained. They can't simply trade, I'm a great oncologist. We have to prove the fact. Are you really a great oncologist? What is your outcome? What is your mortality? What is, when you do surgery, what is the post-op mortality? We have to know. And how often you do this surgery. This is quality of care, outcomes, digital pathology. And again, therapeutic pathology, very important. Case study, discussion. Pathologists and molecular imaging, diagnosis play a very important role in understanding disease. Nuclear medicine, very important role, you will hear about it. And again, this is to show molecular classification. So this is the power of precision medicine and how we kind of really get the best out of based on the therapy. What is the right therapy for you, not the protocol. Is this protocol right for you is what we should address it as we go forward. And evolution of genetic genomics, I mentioned how we have done over 2,000 cases. Recently in Nature, our article came. And this is showing in a nutshell how we manage cancer, precision medicine, immunology,
various things. Today by blood test CTC, circulating tumor cells, I can say whether the cancer has responded or not. It's called MRD, minimal residual disease. We are doing this now to see when to stop the therapy for an advanced case. This is MRD will tell us. So this is just giving you a flavor of what and how we can bring these kind of therapies here. Very soon it is already there, and this is the number of cases. We have done 2,500 cases, one of the globally largest cases of 500 sequencing, published the data on this, how we showed that nearly 69% because of the precision medicine, even in advanced cases, are alive today at 2 years. So this is to show how we can make a difference and how full-fledged program should be done, sequencing, not partial sequencing. So with all this, again, I mentioned about resistance. Why does resistance come in a certain who is Herceptin positive? This is the reason. There are other factors which make it negative, and we need to understand. So resistance is 40% of the time, 40% of the patients are getting unnecessary treatment. How do you overcome this? Through different pathways? Lung cancer, prostate cancer, various factors which cause resistance to various treatment. So innovation is playing an important role, and spatial genomics I mentioned about. So I won't take much time here except to say that this is how Dr. Kallur and team is going to show the various forms of therapy, how complete remission even in advanced cases can be obtained. And this is where, again, showing complete remission of patients treated by combination therapy with immunotherapy, FAPI therapy, those with advanced cases thought to be untreatable or treatable today. This is showing complete normal scan. So I will just go to the end part of my discussion. How tumor boards are important. Whether you're sitting in Bangalore or Nairobi, you don't have to travel. Tumor boards are there, technology is there. Nairobi is very advanced in technology, one of the most advanced cities, a country in the world. So we can easily do this, bring up difficult cases, discuss with the team and come up with an answer. This is how we conduct tumor boards on Tuesdays. Nearly 400 oncologists come on board to discuss difficult cases and come up with answers. And this is to show some cases. I will not really take much time just to show how low-dose immunotherapy helped a man with a locally advanced exophatic mass in the buccal mucosa, which I mentioned. Here is a large tumor you see on your left side, how the tumor is completely gone with just immunotherapy. Almost 100% remission with immunotherapy, and that too low dose. Clearly showing that it plays an important role. And again here, metastatic poorly different, unknown origin. I only treated this patient, we didn't know where. Immunosensitive, PD-L1 very positive. So I gave her only immunotherapy, extensive disease in the neck and axilla. Everything is gone. When we did the surgery, not a single cancer cell. Complete remission. How did this happen? Otherwise this patient would have taken chemotherapy, not response, surgery, but just pure immunotherapy because she was immunogenic, complete response. I don't know how long she will respond. We are keeping a monitoring her to see what is the length she may respond. She is still on low-dose immunotherapy. So these are some of the mysteries of cancer as we unravel. And again, a light lateral border of the tongue. Tongue is one of the worst diseases to treat. How we are able to get CR, complete remission in say, with combination of immunotherapy and chemotherapy, low dose. And it is remarkable where we are seeing with wide excision, no cancer cells, CR. So these are some of the things. Look at this patient. Baseline cancer, large tumor. As we treat and post-op. After all, post-op, this before-op, this is post-op, no disease at all. Absolutely no disease. We did undergo surgery, no disease. Complete remission. So these are some of the things. In lung cancer, as I mentioned, lot of advances have happened in lung cancer. And this is again showing how people can go into remission based on targeted therapy. So I will just, at this point, I'll just move on to the last part of my slide. I will not, this is the last part. How we bucket. It's very important we identify patients who respond, who don't respond, and based on the genomics, start bucketing them to A, B, C, D, E, F, wherever it takes us. And when the next patient comes, we decide what bucket the patient, not what protocol, what bucket the patient comes to. So in that case, can the patient get a better response compared to normal protocol?
Our whole idea is get nearer and nearer to the 100% CR, 100% long-term survival. Can we do that? That is where we should go towards and not accept 20%, 30 or 40, 50%. So this is the way. I have also written a book called Excellence Has No Borders. The idea behind that is it doesn't matter whether it is Africa, whether it is India or anywhere, excellence has no borders. If you do excellence, the disease can be treated the same way and get multiple response. When I went to US as a young man in 1975, I practiced after my MD Anderson in a town which was mostly local people, 100%. I was the only doctor from outside India, and people came from 100-mile radius. I used to see 100 patients a day because that is what taught me excellence has no borders. Wherever you come from doesn't matter. Whichever country you belong, I think you're doing the right thing for the cancer will give us the result.
I've been given the opportunity to talk about the impact PET-CT scans and the imaging in the radiation oncology space. I'm sure many of you are clinical oncologists practicing radiation oncology and chemotherapy. And I will just come to the main crux of my talk, which is about case capsules, how we have integrated PET-CT scans, imaging into our protocols, and how we have integrated AI, radiomics into our clinical practice and created an impact in our patients. So you can see if you just take the anatomical imaging, so just a CT scan, there's a lot of damage in the lung. You know there is a tumor, but for a radiation oncologist, when you're dealing with accurate delineation, it is very important to map the tumor. So here you can see the uptake. This is a FAPI scan where we can exactly see the tumor area, and we usually contour this area. So it's very, very important for us to differentiate tumor from atelectasis. And with PET-CT scan, the activity helps us determine what is the tumor component and what is the atelectasis, where we can even dose escalate and give very, very good impact to our patients. So now as a radiation oncologist, we optimize our fields accordingly, and most important is quality of life. So our intention is to give maximum dose to the tumor and to reduce the doses to our normal structures. We at HCG Hospital, we have incorporated adaptive radiation planning with online intelligence, artificial intelligence, where before our treatment planning starts, we integrate PET-CT scan into our contouring protocols. So during the process of radiation, most of your radiation oncologists, where we know that patients undergo 35 fractions of radiation, up to 30 to 35 fractions. So during the course of the treatment, there could be changes in the anatomical situations of the tumor, and there could be reduction in the metabolic activity of the tumor. And how do we integrate? So with the online adapting, we can dynamically evaluate, assess the response, and then give excellent outcomes to our patients. So this is the biological adaptive treatment, what we do at HCG hospitals. So this is a locally advanced cervical cancer. So wherein, in the midway, we performed a PET-CT after 3 weeks. I think Dr. Ajay was talking about genomics, proteomics, etc., and integration of artificial intelligence. What technology has made is also analysis of the response to treatment during the course of the treatment, and how we can adapt to the changes, and where we can increase the doses to give optimum outcome to our patients. So this is how, like for example, here you see we do a lot of dopamine PET-CT scans. Even in Africa, the PET which has come up at HCG CCK, there are multiple molecules which are being incorporated into our domain. So we also will be getting DOPA scan shortly, which is mainly used for brain tumors. So here you can see the MRI. So there is active tumor, but which are the active component inside the tumor? So that can be mapped by the dopamine activity. So this is linked to the gallium and tagged to the dopamine receptors, where we can exactly map the active component of the tumor. And as radiation oncologists, we can boost those tumors either with SBRTs in combination with the regular IGRTs to give optimum outcomes. So this is again oropharyngeal cancer. We know this was a patient of oropharyngeal cancer with HPV positive. So we know there is a lot of studies on de-escalation protocols which is happening. And here also we've incorporated the biological information wherein we have started using adaptive boost dose to the hypoxic zone. So we also use a mesopet where we can use hypoxic targeting strategies to create good outcomes for our patients with excellent local control as well. PSMA, I think I was just reading the literature, probably around 5,000 new cases to 7,000 new cases every year in Kenya. So that is one of the eye burden diseases. PSMA scans have created a great impact. So we in radiation oncology, if it is intermediate risk or high risk, we tend to integrate hormonal treatment followed by CyberKnife. And you can see the lymph nodes, the main prostate can be easily mapped, and just by giving 35 gray in 5 fractions using SBRT, you can have excellent control of the disease. So you can see how accurate we usually tend to integrate MRI and PSMA PET CT scans. We also have tried dose escalation as well, up to 45 gray to the core using CyberKnife, and with utmost image guidance, excellent control of the disease, excellent control of the PSA with least amount of toxicity is attained. So this is one other, Dr. Ajay was talking about research, so we do have a research fund. So one other important component is we don't follow the West. We try to integrate our own protocols. We customize according to our protocols, and that is what Dr. Kallur has also been doing with PET CT scans, where we have 14 molecules, which I think nowhere in the world they do. So that is the USP of the cancer care in India, and that is what we would want to get to the HCG CCK Centre as well. So this is a core tumor irradiation wherein we just treat the core of the tumor using the PET activity. So we are sparing the peripheral lymphocytes. So you can see this is a patient where multiple lines of treatment, lot of concern, and you can see within around 3 weeks there is regression of disease. So this is a lot tried with proton and carbon ion, mainly in Med-Ostron, Austria, and we have tried to incorporate it using SBRT using a photon, and this is still in an evolutionary phase, just to prove that radiation is not just to destroy the disease, but also it creates an immune impact, and we can protect the peripheral lymphocytes so that they could infiltrate into the core of the tumor and create an abscopal and the radscopal effect. So this is the exciting thing. So me and Dr. Ajay, we were, seeing a patient of prostate cancer, and the patient had tremors in his hand. So we never thought, we just read in the textbooks that Parkinson's used to be treated by radiation. So we came in with a concept, Dr. Ajay and myself, we came in with a concept of treating Parkinson's disease with, CyberKnife. So this patient had a left predominant hypoactivity. So you can see Dr. Kallur has done a Doppler scan wherein there's hypoactivity. So the patient has tremors on the right hand. So we have done a total of around 41 patients right now, highest in the world. So now the patient is tremor free, and we have also started treating a lot of other symptoms like dyskinesia and bradykinesia, wherein we target the globus pallidus internus and the subthalamic nuclei, and helping patients have excellent quality of life and having good control of the tremors. And probably in the next few months we will also get into the dyskinesia aspect and the bradykinesia aspect as well. So this is how we do it. We integrate artificial intelligence. There's an auto-contouring platform. We integrate the dopamine PET CT scan, and this is just the WIM nucleus, the ventral intermediate nucleus, wherein we focus. And this is the internal capsule, which is the most important. So if I get the dose here, the patient is going to have paralysis. So this is how accurate we can treat, and that is why integration of robotics and artificial intelligence to map the tumor, map the lesion. So this is how we do it. So this is another exciting scan. We do a lot of benign tumors as well, acoustic schwannomas. So Dr. Kallur has come up with an integrin molecule, wherein you can see the acoustic schwannoma. This is the brain stem, and you can see, for a delineation, this is going to be excellent because you're going to give up to 30 gray in 5 fractions. When you give this high amount of dose, there could be edema and there could be impact to the brain stem, and patient can have deficits as well. So this is how we treat. Okay, so you can see the shrinkage of the tumor and the brainstem protection by using this.
So this is again brain, F-DOPA, I've already spoken about it. Mainly there is a big component of pseudo progression of brain tumors, GBMs, astrocytomas. With the dopamine scan, we can exactly predict if it's actual pseudo progression or actual progression of the tumor. So it helps us to add an important drug called bevacizumab, which helps us in reduction of the tumor, and we've used a lot in African patients to create good quality of life impact to our patients. So coming to my last aspect, so this we talk about artificial intelligence. I think we are in a space where we need to see artificial intelligence like a mirror. So we have an opportunity to integrate artificial intelligence into our cancer care to create impact to our patients. So if this protocol, we did it in 2017. If a patient comes to my clinic with a PET CT scan, can I predict what is the chances of this patient coming back with a disease after the end of 2 years? So we came up with this protocol and we found 2 imaging biomarkers. You've heard about blood biomarkers, but we developed imaging biomarkers wherein V90 and extent, with a sensitivity of around 93% and 87%. I think we have taken it up to the next level wherein we have started integrating a lot of EGFR, ALK. We have also got into federated learning, integrating artificial intelligence into our protocol. So these are some of the things. So last slide. We never thought radiation can treat osteoarthritis. Now we can treat osteoarthritis and reduce pain and create significant impact. With this, I conclude my slides, and thanks for the invite.
Good evening. Thank you very much for coming here despite your busy schedules. And we are very happy to announce that we have just started doing PET scan. And I'm also very happy to announce that what is being done in Bangalore, we do different types of PET scans. Same thing is going to be repeated here. And some of them are cutting edge molecules, where even it is not done in many European countries and even in USA. In nuclear medicine, USA lags behind, okay? So these all cutting edge molecules are there for your patients now, and it will definitely help to diagnose your cancer patients in a better manner, most precise manner, so that you can precision oncology you can practice. So with these words, I'll just start my talk. And PET scan is there, okay, and it is there for last at least 3-4 decades now. And in Kenya also, PET scans are there, cyclotron is there. Then you must be wondering what this fellow is coming and talking here. Okay, I'm not going to talk about what is routinely practiced elsewhere in the world. 90% or say 99% of the time, they do what a PET scan called EFDG PET scan. Here it is being done because that is the one which is available here, and they are doing a good job. But many times only FDG PET scan is not going to help. So that is where we are trying to give new tracers so that they can have a better diagnosis and better treatment. We'll start. FDG is there for a long time now. I am going to talk about non-FDG, why we are doing. And initially, when we started in our center also, there is anything new. Your questions are always asked. Why? It is already there. Where are guidelines? Why you are doing this? What is the advantage? Okay, so all those things are answered. And we started way back in 2019, this one. And today we are doing mainly the FAPI PET scan. So here I declare that I have no conflict of interest. We published this data. FAPI PET scan, will it challenge FDG? So this we published in 2021. It made a lot of noise, okay, because that was very first to be published in SNMI. And what is the concept? What is FAP? Here, fibroblast activating protein we are seeing, and it is seen in 90% of all the common cancers we see. It is overexpressed. And what is the concept here? What is happening in a tumor? Say, for example, a surgeon removes, say, 100 cc tumor mass and gives to pathologist and asks, remove only the cancer cells in that. Out of 100 cc, there is only 10 cc. It was a surprise for me also. It is only the 10 cc which has a cancer cell volume. Rest 90%, it is a tumor microenvironment, which is our own body tissue, which forms a supporting structure for those cancer cells. The moment the cancer becomes 2 millimeter, it needs a supporting structure through which it is like building block. It needs blood transfusion, blood supply, nutrients, so many things. And this is also responsible for all kinds of tumor resistance. And this is a cross section, this is a histological image here. What you can see, it is a colon cancer cell. The blue cells, what you are seeing are the cancer cells, but look at in that cross section, how much are the Fab cells? Fab cells, what are Fab cells? Our body is full of fibroblasts. The moment it comes in contact with the cancer cell, they are very, very wise guys. They send a signal, hey, come and join with us. And for every cancer cell, there are 10 fibroblasts which surround the cancer cell. Moment the fibroblasts come in contact with cancer cell, they are called as cancer-associated fibroblasts. They are called CAFs. And this forms the bulk of the tumor. So when we want to diagnose, it is a very attractive target for me, because for one cancer cell, FDG, but there are 10 other cells which are much more in surface area. So it becomes very easy for us to see 10 cells versus 1 cell. So this was the concept which was developed, and the blue cells are what are called as CAFs, and you can see here the blue cells surrounded by the CAF cells, and the CAF cells express FAP, fibroblast activating protein. So what is available now is fibroblast protein activating inhibitor. So we add an isotope for that, inject, and it will identify the tumor in a much more precise manner. Beautifully, you can see the images which I am going to show you now. We started in 2019, we were doing 240. So initially, we also had hesitation. Oh, this is new one. Am I going to miss what is the standard, gold standard now, FDG PET scan? So we started accumulating the data, FDG versus this, slowly. And in 2021, we had to jump, because that is when my cyclotron, because of the COVID, it shut down all my guys. They were stuck because of the ban of the movement of the people. They were all stuck, but the patients were coming. So that is when we started doing the FAP scans, for which we don't need a cyclotron. So you can suddenly see that 2020 onwards, from 2019 to 2020, it jumped. And we are doing more number of cases now. And today we have done more than almost 25,000 cases now. And we are one of the largest in the world. And we are doing almost, if I do 1,100 PET scans per month, out of that 700 are FAP scans. The FDG we do only the hematological malignancies, and we have found that in all other malignancies it is good. I'll be showing you some examples. How we do? No special preparations required. Whereas you have seen when you send the patient for FDG, overnight fasting, they have to come in the morning, because FDG is available only in the morning slot. Because whoever will supply, they will supply maybe up to 10 o'clock, 11 o'clock, maximum up to 12 o'clock. So the patients have to come. Suppose the patient has come from far off place, missed the flight, missed the bus. If you lands at 12:30, you say, sorry, you come tomorrow. It is really cruel on our part, but we can't help it. Whereas this, it is available round the clock, because we have the generator. Whenever patients are there, we can elute and do it. And there's no special preparations required. When we are doing FDG, we ask the patient to fast, because we want to bring down the glucose level, so that radioactive glucose I give, it will go and localize and identify the tumor better. The problem in Bangalore, we are the diabetic capital of the world. When the patient comes, we always check the blood glucose, which is done all the centers here also. And we had to send back at least 4 or 5 patients every day, because their blood sugar level was more than 200. We were discovering many diabetic patients in our PET scan department. They were selling it is not there. So we were not able to do. Here, diabetes is immaterial. We are not dependent upon the blood glucose level. Fasting not required. They can eat and come. We usually ask them to come about 3 hours fasting, because we do contrast CT. So it is that easy now. And we started doing the studies, and we have one of the very fast scanners. within 30 seconds we have done the whole body scan, and you can appreciate the uptake is so fast. By 90 seconds you can see the breast tumor, which is a CA breast. 90 seconds you can see. By 5th or 10th minute you can already see that it is seen only in the tumor, rest of the body it is washed out. So say you can see 60 minutes. There is no significant difference between 10th minute image and the 60-minute image. This is very interesting for us. The patient we are made to wait for 1 hour. Now inject 10 minutes, you start the scan, by 20th minute patient is out. So the patients who were doing FDG PET scan earlier, they were surprised. Have my PET scan has been done correctly, or any mistake or any problem with the machine you are sending me out? So this was how they were talking. So within 10 minutes it is out now. It is very fast, and we are very, very happy. And here we do what is called as SUV calculation, because we wanted to know the PET scan done at 10th minute, 15th minute, does it differ from the SUV at 1 hour? So hardly there is any difference. You can see what is done at 12th minute and SUV is no significant difference. In fact, the SUV is slightly higher if we do at 12th minute, and we are doing at almost 15 minutes after giving injection. And the uptake is so fast. Sometimes you might have seen CA breast, or carcinoma stomach, etc. Even though you are referred the PET scan, sometimes you will not see the uptake at all. Okay, some malignancy, they don't take FDG. They have paid through their nose huge amount. Here, it is uptake is so fast. Just to show you that we can diagnose within 30 seconds. You can see the image here in the last image. The tumor is visualized at 30 seconds after giving the injection. And I'm just showing whatever is seen in 30 seconds is not missed at 1 hour delayed. We have given more time for the isotope to accumulate. So it is that fast, and we are really happy with the outcomes. And these are the cases, FAPI versus FDG. This is how you will come across almost 29 to 30 typical cancer cases, varieties of clinical scenarios. This is how you will see, and you can see beautifully the images. There is no background activity. You will see only the tumor and no background activity. Sensitivity and specificity is very, very high for the FAPI. Here I am just showing you, because here I am sure many of you will be questioning, FAPI better, FDG better. Here I am showing you some of the cases where same patient has undergone FDG PET scan and it has undergone a FAPI PET scan. Examples are pancreatic scan. The top rows are all the FDG PET scans. The first you can see that it is a pancreatic cancer. Look below, it is better seen. See the esophagus, whatever is seen in FDG you are not going to miss, or you can even see better. Here it is a lung cancer, top one FDG, where it is seen better, FAPI it is seen better. Head and neck cancers, better seen in this. Colon cancer, you can see it is again better seen. You are not going to miss at all. Don't have that apprehension that, oh, this is a new drug, new PET scan, FDG is supposed to be the gold standard. Am I going to miss it? You are not going to miss it. Now, I will be showing you some examples of a breast cancer, patient 1 and all those things. You can see what is there. You see the first column, the first patient, FDG. Am I seeing the tumor there? See the FAPI scan, you are seeing so much of disease there. Again, the patient 2, you can see the amount of disease missed in the FDG PET scan. But look at the amount of disease, extensive disease burden you are seeing in the FAPI scan. Patient 3, look at that. It looks almost normal, but you'll see the amount of disease there in the FAPI scan. So if you see all those patients in the breast cancer, this is just an example of what is not seen in FDG, we are seeing it. And much better, the tumor disease, the staging also is upstaged in most of the cases. Here, bigger picture here. Look at this FDG PET scan, carcinoma breast. Hardly you can see any tumor there. There is a lytic lesion in the bone. You can see it, the left side. See the image, same patient, FAPI. You are missing so many things. Supposed to be a gold standard now in FDG, but look at the same patient on the right side. You are seeing an entirely different picture. So this is what is happening now. Another example of same breast cancer. See the the comparative images, the diseases, the lymph node metastasis, the primary tumor, any visceral organ metastasis are better seen in FAPI scan. Head and neck tumors, so you can see the more number of lymph nodes here and better delineation in the FAPI compared to the FDG PET scan on the left side. So the sensitivity and specificity for head and neck tumors is far superior in the FAPI scan compared to FDG. Oral malignancy is very, very nice. We really like to see those images because you might have seen in tongue cancer, when you are doing FDG, the tongue, when their patients are talking, the whole tongue is slightly hotter and you have to really search, use your ingenuity to delineate the tumor border. Here nothing, because we are not dependent on the FDG uptake. You can nicely see the head and neck tumors, and without any background activity, you can see here. It is beautifully seen. And again, the data says that the accuracy overall, I will not go into all the data there, accuracy is 98% versus 76% with FDG. Now I'll just going through some of the papers have started coming now. Superior, FAPI PET scan superior to FDG in assessing liver cancer. And FAPI is better for gynecological malignancies. Here you can see on the FDG scan, you can see that primary tumor as well as the bone metastasis is seen in the first column. But look at the second column, how the images are far better appreciated. This will definitely come handy for you when you are treating with radiotherapy. Lung cancer, you can see here, FDG PET scan. And the brain metastasis, you might have seen, in Europe and USA, they don't do brain at all when they are doing FDG PET scan below skull, because anything above brain, they do MRI only. But our patients are paying a lot of money. And with the PET scan, now because I don't have any background activity at all in the brain, you can appreciate the brain metastasis also here beautifully. In FDG scan, can I see it? Very difficult, but look here. It becomes so easy to appreciate the brain metastasis in the FAPI. That is the greatest benefit by doing a FAPI scan. And esophageal cancer, you can see the left side is the FDG. Hardly disease is seen. Same patient has so much of metastasis in the FAPI scan. Breast cancer, okay, you have a primary tumor, lymph node metastasis, lung metastasis, brain metastasis. Again here, you can see the brain metastasis very well in the FAPI scan. And the cutaneous metastases are a bit difficult to evaluate by the FDG PET scan. Look here, extensive disease, very nicely delineated FAPI. Why? Because there is no background activity at all. And this is the one, signet ring carcinoma, where it is clearly mentioned that it is not to be done. FDG PET scan, it is not recommended. If you see NCCN guidelines, this particular histopathology, you will say not to be done because they are not picked up. But it is not a problem with a FAPI scan. You can see nicely. And next slide, I will show you a series of patients published. You can see here, the top row is all FDG, signet ring carcinoma. Bottom, you see the amount of disease you are missing in FDG PET scan. It makes a tremendous difference here to do a FAPI scan. So histopathologically, there are certain malignancies which are not FDG friendly. So here, we can see all those cases. Carcinoma, stomach, many types. This was published in Journal of Nuclear Medicine. This is our case. And this is the same image you will see in that article, where you can see carcinoma stomach, locally advanced, plus the brain metastasis. So this is how you can nicely see it. Again, disseminated carcinoma appendix. On the left side, you see there is a peritoneal metastasis. Most of my nuclear medicine colleagues will say there is peritoneal metastasis. But look at the right side. The image, it is so extensive, very well appreciated. Okay. And this is mesotheliomas. They are densely desmoplastic tumors. They have a lot of fibrotic tissues there. So these tissues, these malignancies are nicely seen in the FAPI scan. This was our very first scan which we started doing PET scan FAPI. You can see the date there, 2019. This patient had a pancreatic cancer. Pancreatic cancer, those who have done a lot of PET scans, you will know many times we miss it. It is very difficult. Faint uptake will be there. The first one, we did a FDG PET scan we are not able to identify. Patient was definitely having severe pain, abdominal pain. We didn't know what to do. Call the patient. We had just started. See the second image there, the column. You can see the pancreatic recurrence there. We did FNAC, confirmed. Then, even though this patient had received radiotherapy, now with their precision, with a cyber knife, they have treated only the metabolic tumor volume there. What happens in the third image? See that FAPI uptake is gone. So they have done wonderful treatment here. Why it was possible? It was possible because of FAPI, not because of FDG. So this is one example. And this is a meta-analysis, which is now a lot of papers are coming. If you see our journals, every month there are at least 2 or 3 papers only on FAPI. And you can see this is a meta-analysis of a lot of publications they have gone through, and they have found out that FAPI is good in primary tumor diagnosis, it is good in lymph node evaluation, and it is good in distant metastasis evaluation. That is foregone conclusion now. And how it will help you to do a better radiotherapy. As I told you, that tumor microenvironment volume is much bigger than cancer cell volume. When you are doing a radiotherapy, if you are targeting only the cancer cell volume based on FDG, see the top row, there is a mass seen. But the same patient, bottom row, that disease, the volume, tumor volume is much more. So based on your radiotherapy, if you go with the FDG, probably this patient will come back with recurrence, because this is what is classically described geographical miss. It is not going to happen because you will be definitely involving the radiotherapy portal based on the bottom image. So this is how we are doing, and this is so helpful for the patient. For example, your patient comes from far off place. You want to do radiotherapy planning in the afternoon or in the evening. FDG is not available. So here, this particular isotope or ligand is available throughout the day. So when morning we finish off all the diagnostic work, evening the radiation oncologist, or afternoon they can come, we can inject, and they can plan the radiotherapy. It is extremely patient friendly, helpful for the technologist. It is definitely better in doing radiotherapy planning. Here, this is one of our example how they use FAPI scan for radiotherapy planning. I'll not go into detail. Dr. Lohit has already told you in great detail. And now, the moment you see this, that means it has gained traction. All these guidelines start coming up because the data starts coming. The people in my center, my organization were all questioning me. There is no guidelines. So the guidelines will always take some time, because America has to wake up only. So only then it will be starting. Now these have started coming, the guidelines how to do these PET scans and all, very easy. So the moment this comes means it is going to be a mainstay in future. Now coming to interesting part. So ultimately, what is the role of FAP in cancer? These are responsible for the cell migration. I had a beautiful video, because because lack of time I cannot tell how the fibroblast make the cancer cell migrate to next cell, how they connect to each other. And they are responsible for mesenchymal transition. They have a tremendous role in immunosuppression. This is where you are doing immunotherapy and all. But because of this, your immunotherapy will not work. And it promotes angiogenesis. It causes chemotherapy resistance. And high FAP expression is associated with a poor prognosis. This is a small cartoon. Blue cells are caps. They just envelop. They form an eggshell-like kind of a thing around the cancer cell. And because of that, they have some protective mechanism to hold the cancer cells from your chemotherapy, immunotherapy, or your own body innate immunity. Why it fails to recognize the cancer cell? Because first it comes in contact with the fibroblast, which is our own body tissue. So it says, hey, don't attack me, I am your fellow. This is why the cancer cells will send a signal, you come and join me. And the first it encounters, the killer cells encounters are fibroblasts, so they become quiescent. Though your tumor is infiltrated with the killer cells, WBCs, why they are not killing the cancer cells? It is because of the CAFs. So if we are able to knock out this, so you are going to have a better results. I will be showing you some examples. So this is a cartoon. The green cells are the tumor cells. They are surrounded by blue cells called FAP. If we send an isotope targeting these FAP cells, so it will give radiation to the surrounding cancer cell, because for one cancer cell there are 10 FAP cells. So it will have a good radiation to the by indirect method. And not only that, we are knocking out the blood supply, the immune suppression, everything is taken care of. Here, this is how we see. I call these patients as TINA. This is what I see at present. TINA stands for there is no alternative, each alphabet. Okay? So you have gone, you have done all the treatment, patients still come with a recurrence, then what next? You have everything exhausted. So these patients we have started treating initially. This is what has given a new branch called theranostics. What is theranostics? A diagnostic, we have evidence. Take out the diagnostic molecule, put a therapeutic isotope, inject, and it will go and treat. So this is a famous thing what is told by my senior colleagues. We treat what we see. Okay, we have seen the tumor. And now we have sent an isotope which will go and sit on that tumor. We see how your medicine is treating that cells. This is what is called as theranostics. This is going to become big in another 5 years' time. We are already there, we are doing it. And think outside the box. Okay. Here is a case, a ovary, it had progressed everything. We inserted FAPI, lutetium FAPI, directly into the peritoneal cavity, and you can see the top images after that therapy, because this patient had no other option, but you can see the ascites has come down. I'll be showing you the same patient here. We do a lot of ovarian cancers because they come back with a vengeance, with a recurrence, and we treat and they have a good outcome now. Example, HCG Pet Scan thyroid cancer, you start with lenvatinib, still progresses, give lutetium FAPI, so you are knocking out the resistance for that. The patient in the third image has responded there. Okay, so these are things happening now. And these are all the types of cancers, all TINA patients, when they had everything, it was progressing. All these are lutetium based images where it is going and treating those tumors. And this was one doctor only, very rare tumor, dendritic cell sarcoma. Sarcomas are very difficult to treat. Nothing works there. So this is where we have given lutetium FAPI. You can see the uptake there in the middle. And there is a definitely visible reduction in the tumor size. Cholangiocarcinoma is one of the most densely desmoplastic tumors, very difficult to treat. Okay, nothing works there. They are resistant for all kinds of therapies. This is one of our case. 22 we did, and the third and fourth images are post-lutetium FAPI therapies, where you can see the tumor has already vanished. This was inoperable case. Cholangiocarcinoma is not operable most of the time. It was inoperable. We made it operable. Why? It is because of FAPI scan. Based on FAPI, we did lutetium FAPI, and the patient is fine at 3 years now. At the surgery, it was only necrosis. So this is how we are able to do it. These are some of the cases, very difficult. These are called hemangioparasitomas. They are densely desmoplastic tumors. And you can show that these are the images showing whatever dose I have given goes only to the tumor. Because it goes only to tumor, there are no side effects at all. There is no bone marrow suppression. It goes only to the tumor. Difficult to treat some of the cases, neuroendocrine carcinoma. Neuroendocrine tumors, you can treat with lutetium dotatate, but if they are aggressive, then FAPI goes there. We have a treatment option nowadays. And we have just introduced a new molecule for hepatocellular carcinoma. Okay, this is called as Glipican. This will be available in this country also. What is Glipican? It is glycoprotein, which is a particular type of, it is overexpressed in hepatocellular carcinoma. First scan, same patient, 3 scans we have done, FDG, FAPI, GPC3. This is what is happening now. Different cancers are better seen by different molecules. FDG is not the only one. So you can see GPC3, and we have used that GPC3 for therapy also. Highly targeted, you are not seeing radioactive going anywhere. This is what can be done in your country also. This is one which is quite rampant in this part of the world. And PSMA scan, gallium-68 PSMA scan. You are doing PSMA scan here. There is a 3 months waiting period, I believe. Now it is available around the clock. They can come and every day we can do it. What you want to know? This is one scan which has made a difference how you diagnose and treat prostate cancers. So you can see the primary tumor nicely. What you want to know is the lymph node metastasis and the bone metastasis in one investigation. Within 1 hour we can do it. It is available round the clock now. And even when PSA is so low, no medical oncologist or surgical oncologist or uro-oncologist will advise any PET scan when PSA is at this level. But just to show that we don't go only by the blood test, you can see why the PSA has started rising, because PSA should be undetectable in a radical prostatectomy done. So why it was rising up? It was because of the lymph node disease which we have identified here. And this one also we will bring it. This is what is called as CXCR Pentix of 4. This is extremely good for certain hematological malignancies, multiple lymphomas and also multiple myeloma. So FTG in our center, we limit only to hematological malignancies. CXCR4 is also possible, we will introduce here shortly. And hyperfunctioning parathyroid adenomas, classically you do what is called a sesame B scan, but many times we miss it. And example here, left side you are seeing a sesame B scan, not able to identify, but look at the what is called a trivexin scan. Exactly, you will see. And we do lot of these cases referred not by physician but by urologist, because frequent nephrocalcinosis. So first this suspect is a hyperfunctioning parathyroid adenomas, and we are doing this. Anything happened here? Or it is telling me stop? Okay, I am about to finish. And neuroendocrine tumor. This is first time happening in this part of the world. Neuroendocrine tumors. I was getting lot of your patients referred to Bangalore. They are just coming all the way for this particular scan. We have just started doing it. It is somatostatin receptor analog, neuroendocrine tumor. You can see and you can diagnose very nicely, and same thing can be used for therapy also. This is what we will be introducing in another 5 months' time, a specific ligand for renal cell carcinomas. Nobody on earth can tell based on this one top image. There is a small cyst here. Can a radiologist tell it is a malignancy? No. They say neoplastic etiology, but that your treating doctor is not happy. He wants a specific answer. So we are about to start what is called as CA9 image, again gallium based isotope. The work is in progress because we are developing this molecule. And see on the top it is there. So that small lesion what you are seeing is definitely cancer. So what happens even before they do anything, you already decided, because you cannot do a biopsy here. It is dangerous. It is to be avoided. Straight away patient can go for surgery, do nephron sparing surgery. This is how it has helped. But what is happening below a complex renal cyst, it may be difficult to identify whether it is malignancy or not. But is there any uptake there? No uptake there. You can wait and watch. It is a benign condition. So this is another one. And same thing, we can use it for therapy also. You can see the lot of metastasis, and it's theranostics. So we take out gallium, put a lutetium, inject, and your metastatic disease also can be treated. These are all the things happening. And this is how we report. Our reports are very, very exhaustive. I'm only telling at the end, we give all the information and we try to give TNM staging. Okay, so that it is like almost a tumor board meeting. You can see one of this is a carcinoma prostate. You try to give TNM staging. First you can see it is why it is T4N1MB. It becomes very easy if I tell in one glance, because you are busy practitioners. Why it is T4, it is mentioned there. Why it is N1, it is mentioned there. Why it is M1B, it is mentioned there. Everything we are mentioning, and we also try to give additional information to you. Look here, I am seeing abnormal here, additional interesting things. If it is there, we also mention. This is one of the examples of carcinoma prostate. And in the beginning, we have mentioned high risk Gleason score with very elevated PSA, and these are the things which will come as a last page. So our reports are very, very exhaustive. And this is another example of carcinoma hypopharynx. We have clearly mentioned what is the TNM classification which we follow, and that AJCC classification. And you can see primary tumor, why it is T4A, N3B and M1. If you go through all those things, we have clearly mentioned so that you will not waste too much of time. Because what happens many times I have seen, they again come to us, you tell me what it is, we are also busy. So what happens, we have already given you why it is T4, why it is N3B, M1, so that it will help you a lot, cut down your decision making in the tumor board so that you can decide what you want to do. And what is offered right now in Kenya is FAPI. We are doing routinely every day, available from, if they are willing to do 5 o'clock. My department in Bangalore starts 5 a.m. First patient is at 5 a.m. My last patient is at 4 p.m. evening. If they are willing to do, they are ready to do, because available isotope round the clock. And PSMA, it is happening now. And Dotonac, happening now. GPC3, I'll be sending it. At present, we are producing that. It is a bit difficult to produce. We'll be sending for hepatocellular carcinoma, Trivexin, and CA9 will be sending. The last one is very, very interesting. Now, when you see a breast, based on the sample what a pathologist gets, that pathologist will tell ER/PR positive. But you want to see whole body disease burden, because it may be positive only in that sample or it may be negative in that sample. Whereas here we are able to tell ER/PR positive based on the image. I have not gone into detail, even before pathology report comes, based on the image and whole body disease burden. So this will definitely come in helping to start your hormone therapy. And if they become hormone resistant, I can come there. I can also come and treat lutetium NPY1. So like this, so many new tracers are coming. We are doing almost 12 different types of PET scans. We will definitely introduce them one by one, because my technical staff, my radiochemistry guy, they have to hone their skill, because I am blessed with good radiochemistry of PhD caliber. 3 guys are there. They do it. But here it takes some time. But at present, without any failure, most of these scans are being done. And your patients in this country are going to get all these cutting edge molecules every day. So the patient need not go to any other country. They need not come. Many patients who are coming to me for follow-up, now I already told them, don't come for this scan, you get it done there. We are reporting, and my colleagues are there. Harish is there, they start reporting. And this is available round the clock. And thank you very much. This one I want to show. This is very important slide. Okay. And all these years, my wife, you can say FDG. Okay. You see how she is giving very nasty looks, because I am attracted to this lady now. Okay. This is what is happening. And definitely it is being done right now, every day. And there will be questions asked, even though nobody will accept that. But now the data has accumulated so much. That is why I'm attracted to the FAPI now. Thank you.
Thank you very much, Dr. Kalur. Please a round of applause for him. Dr. Kalur, I'll ask you just to stay on stage a little bit. Please a round of applause for him one more time, ladies and gentlemen. Now, Dr. Kalur, we have a special gift for you just to celebrate you. I mean, I don't know when you sleep, I don't know when you rest, because you're always working around the clock. But to help us present this particular award, or rather not even award, special gift, I'd like to welcome Dr. Adam Ali to join me up on stage. And he'll be joined by our chairman of the Vanguard Group, Mr. Bachu Patel, as they officially present a special Masai Shuka to this amazing gentleman that is super determined to ensure that Kenyans are well. Please, one more time for Dr. Kalur Tafadhali. Dr. Bachu, Mr. Bachu, you can please come on. You want to say something?
I think what we have, I would like to just mention that Dr. Kalur is world authority on PET scan. And we are so happy that we will have somebody like him monitoring all the work that we do here in Nairobi. He is definitely a world authority. He arrived 3 days ago from India, and from the airport he straight came to work. And since then, every time I've gone to the PET scan river, he's sitting there and guiding our team up here. So thank you very much, and we are very much thankful for for the lovely lecture you given today. Thank you.
So I'll ask you, both the three of you, just to go to the middle so that we can get a perfect picture. Please, a round of applause for Dr. Kalu. So we're going to put out a special Masai shuka on you, and just to celebrate how special you are to us in this particular region, and hopefully you can come over and over and over and over and over again. Please, a round of applause for him specially. Don't jump just yet. Oh my goodness. So I'll ask you guys to flank him on either side so that we can take a picture with him, with our resident warrior, our Maasai, this amazing evening. Yes, now he looks like the Fapi in the red, amazing shuka. Please, one more time for Dr. Kalu. Thank you very much. Thank you very much. Thank you very much, Mr. Bachu. Asante sana, Dr. Adamali.
Good evening, everyone. I know you're already approaching the dinner time, so I will not be taking much of your time. And the reason we put the panel is just to make it more interesting and to have insights from our panelists, cut across radiation oncology, nuclear medicine, and clinical oncology, as well as we have distinguished guests from India. So we are going to put up some case, and it will be an open discussion. So our guests have not seen the cases. Actually. Our panelists have not seen the cases. So okay, let me stand and make it easy. Okay. So this is a case metastatic CA breast. If you look at it, was taken on 18th of May 2019. The images you are seeing are MIP images. And of course, by now, Dr. Kalura has taught us we can clearly differentiate with this FDG and FAPI, because we don't see any activity in brain. It is FAPI. Okay, that is something we can tell for free. So, going straight into it, this patient progressed on all possible combination of chemotherapies given by the oncologist in the MDT. Even hormonal therapy was given. So the question to the panelists now, probably Dr. Joki can take this case. What do you think next can be done here?
Thanks for starting me out on the hardest question. And I think maybe I'll ask Dr. Kalu to mention, because maybe it might be one of the TINAs that he talked about.
Yes. This patient came to us actually from MSKCC, Mecca of cancer treatment. They are told that nothing can be done. The first image is when we did the FAPI scan, and that time I had requested Dr. Ajay Kumar and team. They said, nothing doing, you are doing something new, we don't know. There are no guidelines, okay, naturally. Then I said, you please go ahead. I was waiting for them to come to me. Second image is after their salvage chemotherapy which the patient received after coming from USA. After salvage therapy, what you are seeing the image is a progression of the disease. That's when Ajay Kumar told, okay, let us do something. What you are talking, you can show. So the next one is, the first two images I have already told. The third image what you are seeing is after the first actinium. We have used actinium FAPI therapy there. You can see a good amount of response compared to the second image. The second image, she was pronounced, okay, nothing can be done, write your will and go. But the third image we gave, Dr. Ajay Kumar is the one which will never say no to any patients. So we gave this therapy. You can see that there is a response. But he told, Kallu, I will add chemotherapy next. The fourth image is after FAPI therapy followed by chemotherapy. This is what I told in my slides. The tumor microenvironment acts like a barrier or a chemo-resistant things. What we have done here, we have knocked out that barrier. Along with that, we have killed some amount of the cancer cells also. So the fourth image what you are seeing here is after chemotherapy, which we gave after second lutetium therapy. So here is a proof where when there is nothing possible, TINA, there is no alternative. Okay, we have given first therapy, and Dr. Ajay Kumar made us to think that adding a chemotherapy will definitely help, and this formed the basis for us that our future FAPI therapies are always followed by our lutetium FAPI therapies are always followed by chemotherapy or immunotherapy, and we are seeing amazing results. This is one of the examples. This patient lived almost 14 months compared to 2019. Ultimately, she succumbed to the disease, but she survived 14 months, where in 2019 she was said nothing can be done. Next slide.
So this is the second case. If you look at the MIP images again, first one, what we see is 2019 October. Within 1 month, there is progression, and between there was already chemotherapy given. Salvage chemotherapy is given, but now the patient has still progressed. If you look at the tumor markers, CA125, it's significantly increased. These images are of gallium fragments. So
You can throw the question to the other.
maybe
There are a big number of other consultants also.
maybe Dr. Adarsh.
Adarsh.
Progressed.
Progressed.
So what is the next?
Yeah, what we practice is again second line chemotherapy or the molecular based on BRCA mutations, molecular oral therapy that we practice. What happened? Would be interested to see.
Okay. This patient received, after what you told, all the types of chemotherapy, everything was under the sun was practiced, tried. The second image was progression after what you told, all kinds of therapies. She had no other alternative. Then we gave actinium FAPI. The last image what you are seeing is actinium FAPI, and we had starting chemotherapy. The patient was resistant to all kinds of multiple kinds of therapies. The third image, surprisingly, only a single agent, cisplatin, 200 rupees wala, single agent chemotherapy, cisplatin was given weekly, interval 3 cycles, and look at that image, follow-up scale. Surprisingly, this patient is still alive at 5 years. Okay, still alive. I asked a medical oncologist what happened, because I thought this patient never came back to me. I thought patient might have expired. But he told, no, she comes back with the recurrences. I'm not sending to you, but you have made them chemosensitive. She's responding to chemotherapy. Okay, because FAPI therapy is expensive. So they become chemosensitive again. So she's still alive at 50 months now, where she was almost pronounced dead in 2019. She's still alive. This is one of the best examples of what is going to happen in future called theranostics. Diagnostics have an evidence, and you are going to treat as the same molecule, you change the isotope, and they are having a better quality of life ultimately.
So this is a case of adenoid cystic carcinoma, right ethmoid, and we have an axial fused image on the left and a MIP image here. What I can see is something mediastinal, and probably we have Dr. Buku here. He can comment on the axial fused image, what we see, and that's an HCG scan. Dr. Buku.
Yeah, so the image is actually not very impressive. We see uptake in the brain, but no uptake at all at the area that would be concerned for tumor. Yeah, adenoid cystic carcinomas are usually not FDG avid, and we actually, when we get the requests, we tell the clinicians we don't do HCG Pet for adenoid cystic carcinomas. So I'll have to abandon my good girlfriend FDG and look at for FAPI.
You can show.
So that's the image whereby you can see a nice uptake in the right ethmoid sinus, and we can even delineate. And also, what we had not seen earlier was the mediastinal node, which has been picked very well, and that is what the differences mean. And on the same case, probably I can ask Dr. Lohit what his treatment management on this.
I think you can see a clear delineation of the adenoid cystic carcinoma, mainly in the ethmoid sinus. So the most important thing to understand in adenoid cystic is it's relatively chemo resistant as well as radio resistant. So in these patients, we would intend to have a multidisciplinary approach and probably use an head and neck surgeon's opinion to see if maximal resection is possible. If you can get an R0 resection, then when you add adjuvant radiation, probably the outcome is going to be much better in concurrence with probably cisplatin-based chemotherapy. So, but what we do in India is we have a MDT wherein we do genomic profiling. We evaluate if at all any genomic patterns which can be targeted during the course of the treatment, so that just by saying, as Dr. Ajay was speaking, just by saying recurrence is 30% or 40%, it's always important to aggressively treat first time the best way so that we have the best outcome for our patients.
This case, I'll tell you the interesting story here, because there are very early case, naysayers in my organization also, no guidelines I will not use. So in our center, all the radiotherapies are PET CT based, PET CT guided radiotherapy. When they use this, they are not able to draw the line. I was patiently waiting for that. And I said, I will do it free of cost. Let me see, we will try and do it. And this is what changed their opinion about the new girlfriend. So now they are married to that girlfriend now. So all those guys are using, it definitely made a difference. And based on that, they were able to use good cyberknife treatment and all. Not only that, we do so many other metastases which were not picked up in FDG. We were able to see it. And as he told, genomic studies and all chemotherapy you can add. This is one of the best examples where FAPI scores for FDG.
On a lighter note, Dr. Karul, we can't get rid of our wives so easily. I think I'll skip this case because Dr. Karul
already told.
This. Yeah, so this question is for Dr. Ajay. This patient, if you can look at the cropped image, it shows significant disease burden. There's tracer uptake in the bone marrow and diffuse disseminated skeletal metastasis. And also I can see something over the liver there. This patient had almost all kinds of treatment here, and even including radium, 6 cycles of radium. So, Dr. Ajay, what would your option be next?
What is the age of the patient?
Around 65 years. Yes.
So obviously, the hormone resistant and chemo also, and PSA was
2,900.
So obviously, Kallur, I will send the patient to you. But I would also do one thing, because we do see BRCA positive. We will look at hot cold tumor, BRCA. So I will do genomics, which is mandatory in my clinic for all. And then I will send the patient to you to see whether there is any role of FAPI with the immunotherapy. I think these are the things which are going to make a difference. Please go ahead.
Okay, so this patient received 3 doses of actinium PSMA. You can see the first image, extensive disease burden. Next, see the next two. The PSA from 2,900, it has dropped to 0.1. So it's a phenomenal response. It's another classical evidence of what is called a theranostics. The PSMA is overexpressed in all the prostate cancers. So we use it for diagnosis. Next, I put it a therapeutic isotope and inject. So this is what is being done now in most centers in the world. This can happen here also. We will be definitely starting this PSMA therapy. Next, you can see the amount of response. Almost disease is almost negligible.
Kallur,
Yes.
we have to do some trial, particularly here in
Yeah.
Nairobi,
Yeah,
where we
here-
see lot of prostate cancer.
And aggressive also.
We used to
yes.
do a
Yeah.
combination of upfront PSMA.
So,
we should really
yeah.
do that. And
Just,
then
just to evaluate that this is a very hot topic now. Okay. So there is many trials are going on, and most of the trials which I have come across and they have enumerated, I have come to conclusion that PSMA therapy definitely gives better survival, disease-free survival, better quality of life. And PSMA, there is something called upfront because it was at the bottom. PSMA, like anything new, is always at the bottom. So now the data has come so voluminous data that it is giving better response when everything fails. So why you want to keep it at the bottom? Why the patient should suffer for so long? So one trial has started what is called upfront. If the patient comes with that kind of a disease initially, if they are PSMA positive, and we do FDG also, if they are FDG negative, straight away take them for PSMA therapy. One trial is happening. Interim results are very, very encouraging because they are not taking any other therapy, no hormone, no chemo, nothing. So they are getting good results. And there is another trial where, because we all know that prostate cancer, you start hormone therapy. But what happens for the patient, the hormone therapy makes the patient tumor which is behaving indolent becomes aggressive later. So what they are doing, one clinical trial, they are postponing the hormonal therapy later. Okay, let us do it, but not initially. They are doing PSMA therapy now, and they are yet to achieve any. This is just started about 3 or 4 years ago, that the data has come that they still have a good disease-free survival. They are yet to start on a hormonal therapy. So this is one more trial happening. And the last one is very interesting for most of the surgeons here. If the disease is regional with less number of oligometastasis, the lymph nodes are there within the pelvis, N1 disease. So there is another trial which is happening in Australia and in Europe. They are giving upfront lutetium therapy. It is called a lutectomy. Bring down the tumor mass and then subject them for surgery because they also want to do surgery. They are also having a good results, good survival. Those patients are yet to be started on other therapies. So these are interesting things happening. Why it is happening? It is because of the one single investigation called PSMA, which has totally changed the way we are seeing the prostate cancers and treat the prostate cancers. This is one of the examples of what is called as lutetium upfront. This is my own case, a doctor. He said, I flatly refused to treat him earlier because there are no guidelines, because he is a doctor, he will question me. He said, don't worry, I am not going to file any case on you. I have done my own work. I am already 80 now. I don't want to have all those therapies. Let us take a try and give the therapy. Look at that. One therapy dose has responded so dramatically. This is treatment naive, no other treatment given. Treatment naive, and you can see that type of a result. And he came back thanking me profusely. His quality of life has improved. The primary tumor has regressed so well. The lymph node metastases have regressed well. The lung metastases are almost disappeared. So this is how we are seeing what is called upfront. These are some of the examples what is going to happen in future for the prostate cancers.
So this is gallium urinary scan of uroendocrine tumor. I think he had also posted similar case earlier in his presentation. Dr. Joki, you want to take again? Yes, the primary, where the primary, what the treatment option?
Yeah, so this would be the classical patient that you would have to refer out because of unavailability of daughter talk, even to do the scan. And I think these are some of the patients who are quite challenging because you might not have a lot of therapy that can be directed. Somatostatin analogs are maybe what we have, and that would be what we direct the treatment. But of course, the diagnostics become superior for this group of patients.
So this is it, the first image we have shown, and the last two images, you can see how a targeted radionuclide therapy, theranostics, has addressed the tumor. The patient was fine almost 5 years. Patient is still coming to me 10 years down the line. He's still having a great quality of life, no significant toxicity at all, very easy to treat. That can also happen in Kenya. We are going to do that.